not that many people are as nerdy as you or most of us on the topic.
I'll take that moniker.
Yeah.
This material is for reference and educational purposes only. Syndicate, its authors, and associates assume no responsibility for the utilization of any materials or techniques shown or described, nor does Syndicate, its authors, and associates assume any responsibility for patient safety or outcomes. Clinical experience, as well as current guidelines, should determine the exact state or process in each individual patient.
Hello. Welcome to the SimKit podcast. My name is Dylan War, and I am super excited to be here for part 2 of this 2-part podcast series. I had the opportunity to co-host today with none other than SimKit's own Dr. Jason Hine as we talked to the endocrine extraordinaire, Dr. George Willis. We had such a great conversation that we needed to break our discussion up into 2 podcasts. The first episode, we discussed the epidemiology, pathophysiology, and clinical presentations of both DKA and HHS. So check out part 1 if you've not already. In this second episode, we will talk about diagnosis and treatment. In both episodes, we base our discussion on the recently released ADA 2024 Consensus Report on Hyperglycemic Crises. Enough of that. On to the show. So, George, thank you for walking us through some of the epidemiology, pathophysiology, and presentation of both DKA and HHS, and some of the key nuances to these clinical conditions, including euglycemic DKA and diabetic ketoalkalosis. As we move on to part 2 of our discussion here, let's transition to diagnostic criteria and management of these conditions. So George, to start us off strong, tell us about the 8A update and specifically the new diagnostic criteria for DKA. What has you so excited about these updates?
Sure. So first off, these changes are not like, they're not like these monumental changes that are going to make us say, oh my gosh, I've been thinking about DKA and HHS the wrong way. I think for the most part, what these kind of do is give us a tool in our armamentarium to kind of say, hey, I was right all this time. And certainly this patient who looks like they're in DKA is likely in DKA. So the old criteria used 250 milligrams per deciliter for a glucose level to make the diagnosis of DKA. So that obviously didn't address anybody who came in with euglycemic DKA. These new criteria use 200 milligrams per deciliter, which I think is actually a better useful tool. Remembering that 200 is the criteria, a non-fasting glucose greater than 200 makes the diagnosis of diabetes. And so what this does is establishes, 1, this patient has diabetes. 2, if they have a previous diagnosis of diabetes, regardless of the sugar level, that makes the diagnosis for DKA, obviously with other subsequent things, which we'll talk about in a second. So new guidelines, 200. In other words, this patient now has a diagnosis of diabetes or a previous diagnosis of diabetes with any sugar level. So if they come in and their sugar's 10, they could still be in euglycemic DKA. They probably just gave themselves a little too much insulin on that one slug, but they could still be in diabetic ketoacidosis. They also use the beta hydroxybutyrate level. Now, this is another big update from the previous guidelines where beta hydroxybutyrate back in 2009 was really a send-out lab. Now we have patients who have point of care beta hydroxybutyrate testers at home that they can actually use to say, well, my sugar's high. Let me check my serum ketone levels or my beta hydroxybutyrate levels with a quick finger stick. And if their beta hydroxybutyrate levels are elevated, then they know that they need to get to the hospital and they're probably in DKA. Now they're probably going to have symptoms as well that are probably going to say, ooh, maybe I'm in DKA. I should probably go to the hospital. But if they're starting to see that their sugar is like 200-300 and they're like, well, I haven't been taking my insulin. Let me just check my beta hydroxybutyrate level. And it's even a little bit elevated before they even get symptoms. They oftentimes come in mild DKA, and a lot of those patients can get fixed and potentially even sent home, which we'll talk about. So beta hydroxybutyrate, as we know, is the predominant ketone body. And so I love that they decided to use that as their part of their diagnostic criteria, because I think it is available in a lot of emergency departments now, which is great and useful for these patients who come in with potential for DKA, instead of just relying on the urine and serum ketones. We have to remember beta hydroxybutyrate is the predominant ketone body made in DKA. All of the urine and serum ketone assays measure just acetoacetate. And so that beta hydroxybutyrate level is a much better gauge for, is this person in DKA or not? They also use the same criteria that they used from the 2009 guidelines in terms of the pH and the bicarb. So pH less than 7.3, bicarb less than 18 is going to seal the diagnosis for DKA. And that's all of the criteria that they use. In terms of HHS, the criteria for HHS really hasn't changed that much. They still use the 600 milligrams per deciliter for the glucose level. But they do allow for a calculated osmolarity level. So I know that the vast majority of us work in emergency departments where we can get an osmolarity level. However, that serum osmolarity level does not come back quickly. And there are some emergency departments where a serum osmolarity level is unfortunately a send-out lab. But you can calculate an osmolarity simply with a BMP. You'll get a glucose, you'll get a BUN, and you'll get a sodium level. So if you calculate the serum osmolarity, now remember there's a lot of things that can affect the serum osmolarity other than those three things. So alcohols can do it. There's a number of other things that can do it. So a lot of times there is a little bit of a discrepancy between a calculated osmolarity level and a true measured serum osmolarity level. So that they account for that in this new guidelines for HHS, in that they use 300 for the calculated osmolarity level, and they still use 320 as the serum measured osmolarity level. Anything higher than either of those two values certainly is diagnostic for HHS. And then very similar to the old guidelines, the absence of the Ka of DKA, so no ketones and a normal anti-gap non-acidotic state, again, will make the diagnosis of HHS.
And thank you, MD Calc, for existing. I'll just put a plug in there as we talk about calculating serum osm levels.
You don't calculate your own serum osmolarity levels?
On every patient, but I see a quarter patient every hour, so it's a problem. But no, I think this is a great summary. And if you're going to take the article or the consensus statement, take a peek at figure 2. We'll reproduce it in the show notes for you, because I found it actually a really nice, it's not really an infographic, but it's a great graphical representation of how the acronyms tell you about the disease state and actually help you with the diagnostic criteria. So a little bit going back to Sesame Street, breaking down the acronym DKA. D here is for diabetes, which clearly we're talking about. Really groundbreaking change to go from 250 to 200. I thought that was a little bit silly, but important. And then the really important one that we're noticing, history of diabetes, blood sugar 200. That's the D in DKA. K is for ketones, beta hydroxybutyrate over 3 or 2+ ketones in the urine. A is for acidosis, so that's our pH less than 7.3 or a bicarb lower than 18. So nice and simple. Again, reproduced or available in the show notes for you guys to see, or grab a screenshot from the consensus statement itself. Let's talk about HHS next. H, of course, is for hyperglycemia, and that's a blood sugar greater than 600. The second H is for hyperosmolar, so this is an osmolality greater than 300. And that's pretty easy. Sugar 600, osm's 300. That helps my brain a little bit. The S I thought is a little tricky, and they're definitely cheating here, which is the absence, taking the S out of absence of acidemia or ketones. So pH greater than 7.3, bicarb greater than 15, and beta hydroxybutyrate less than 3 and no ketones in the urine. So something valuable if you have Evernote or other peripheral brain, these graphics are nice to have just on hand as a reference. And the more times you look at it, the more it really sinks into your brain. But recognize you can kind of use the acronyms themselves slightly to get through these diagnostic criteria that they posed.
All right, George. So we've introduced several new concepts here. We talked about euglycemic DKA, and then we started throwing around terms like diabetic ketoalkalosis. And now we have this new criteria. And honestly, it makes me a bit confused as to how we should work up these patients. What labs am I getting on these patients when they walk in? Do I need to order a chemistry, VBG, and beta hydroxybutyrate on every single patient coming in with the chief complaint of hyperglycemia or a history of diabetes? And what about urine testing? I guess what I'm trying to ask is, with so many different variants of this diagnosis, how do we not miss it?
So this is a great question, and it's fun because it really takes a lot of the nuance that really comes with DKA out of the picture. So specifically for DKA, a lot of the basic labs that and I hate the word basic labs, because basic labs to me sounds like you're basically just going to say, I know I need to order something, so I will just order these two things and say that I did something, so the patient feels like I did something. So the chemistry that you get in, quote, the basic labs is going to be very helpful for you, not just for your DKA, but also for your HHS, because it's going to give you the glucose, it's going to give you the anion gap, and it's going to give you the acid-base status to a degree. It's going to give you the bicarb level, which will certainly be helpful. It also will help you for the diagnosis of HHS, because you can look at that glucose level. Again, you can look at that bicarb to see if that patient is in an acidotic state. And you can look at that sodium, which is the most important thing. If you see that elevated glucose and you see that that sodium is normal or elevated, again, it should make your anal sphincter tighten up a little bit. I typically do get VBGs on these patients. There is no necessary need to get an ABG, and so it's not necessary to torture a patient's wrist just to get an arterial blood gas, because we know that the pH and all of the PCO2, the bicarb, which is calculated anyway, those will come back very similar between an ABG and a VBG. So there's no reason to get an ABG. Just go ahead and get your venous blood gas, and that's going to be super helpful. And then I do get a beta hydroxybutyrate level if I'm concerned about DKA. I'm not getting a beta hydroxybutyrate level to prove that a patient's not in DKA if I'm searching for HHS. So in that scenario, I'm not necessarily getting a beta hydroxybutyrate level. I still get a urinalysis, not to look for ketones, because I'm already getting the beta hydroxybutyrate level, which is more important to me. But I am getting urine basically to look and see if they have a subsequent or a concomitant urinary tract infection. And so this comes to, again, is there a trigger that spurred this patient to develop this hyperglycemic crisis? But the thing that I oftentimes will get very quickly on these patients, and so if a patient comes in, I get a quick finger stick, and a lot of times we all have access, a lot of us have access to an iStat or a quick point of care VBG with lights, and that's great if you have that. But otherwise, you're going to be waiting on this chemistry to come back or the VBG to come back, which can take 30 minutes to an hour. Another quick tool that you can use is end-tidal CO2. So if you check an end-tidal CO2, which a lot of us can get within a relatively quick period of time, if that end-tidal CO2 is greater than 27, we have effectively ruled out diabetic ketoacidosis. If it's less than 27, it doesn't mean we've ruled it in. We still have to look for other potential causes of a metabolic acidosis, but that end-tidal CO2 will help us to differentiate, no, it's not DKA, or it could be DKA. And so usually if you can get that relatively quickly, that's another tool that you can use in your armamentarium. And then other than that, you're really just focusing on casting that wide diagnostic net to find out what potential stressor could be going on with the patient. So we talked about the urinalysis. I will oftentimes get an EKG on these patients. It tells me two things. One, importantly, does this patient have any signs of acute coronary syndrome or myocardial infarction? And two, does this patient have profound hyperkalemia as a result of their acidosis that's present? Chest x-ray, I have a low threshold to get to look for any signs of pneumonia. Certainly if the patient's having a surgical abdomen or something that makes me think about mesenteric ischemia, I will get a CT of the abdomen and pelvis to look for a potential surgical cause, or get a CTA of the abdomen and pelvis to look for mesenteric ischemia and things of that nature. So the rest of your diagnostic workup is really dependent upon what is the potential stressor. Do I order all of those things on everybody? No. I use my history and physical to kind of whittle down what are the potential triggers, and then go from there.
Sure. I wanted to ask you a little bit about this kind of beta hydroxybutyrate acetoacetate debate that I don't think it rages anymore, mostly because not that many people are as nerdy as you or most of us on the topic.
I'll take that moniker.
Yeah. Well, as I understand it, beta hydroxybutyrate, it's more specific for the diagnosis. Many of us have tests that can kind of look for acetoacetate. I know the quote unquote ketones in the urine, and I believe in the serum is the acetoacetate. And that can kind of
Yep.
underestimate things, if I think of it correctly, in the beginning, because the
Hmm.
beta hydroxybutyrate has to turn into acetoacetate. So in the beginning, it might underestimate
Correct.
and then lag behind, right? And overestimate later in the disease. The ketosis is done. The beta hydroxybutyrate is gone or going down. We're getting rid of that. But now the acetoacetate's being washed out, particularly in the urine. So is that
Hmm.
accurate? And if so, if we don't have a beta hydroxybutyrate, should we kind of be picketing our lab until we get it in our department or in our hospital?
So this is great in that a lot of people, don't look at this very significantly pertinent topic, which is, what do I do if I don't have beta hydroxybutyrate? What do I use to rely on? We have to remember that beta hydroxybutyrate is the predominant ketone body that happens in DKA. Beta hydroxybutyrate turns into acetoacetate in the presence of insulin. So it will shift into acetoacetate and then subsequently broken down into acetone and then subsequently excreted out in the urine. So all of that stuff clears out as a result of the presence of insulin. So it does underestimate the ketone level. If the acetoacetate is normal, we're going to think to ourselves, oh, well, this patient might not be in DKA. So what we need to recognize is beta hydroxybutyrate is better, but if you don't have access to it in your lab, the next best thing to do is to look at the clinical picture and use your anion gap acidosis to kind of help you drive in terms of what you're going to do on this patient. Again, if they look like they're in DKA, ketones be damned. That patient is in DKA until proven otherwise. In the setting of an acidosis with an elevated blood sugar and the clinical picture, go ahead and treat the patient appropriately. Worst case scenario, the patient gets a bunch of fluids, which they probably needed anyway because of their hyperglycemic osmotic diuresis. They might get some insulin, which is going to get their glucose better in any way. And if they're starting to look better from a clinical perspective, then you're probably treating the DKA that you didn't know that you had. But in this scenario, and I've worked in a clinical environment where this was the case, where we didn't have beta hydroxybutyrate levels testing available to us, what you'll notice is that their urine ketone assay will start to actually increase. You'll start to see that changeover from beta hydroxybutyrate into acetoacetate, which as they continue in their disease process, that urine ketone level will come up and then it will subsequently go away as they continue to clear that, as the acidosis is improved with the insulin and the fluids that you're giving them.
So, question for you then, George. Where I work now and also where I trained, we don't and didn't have point of care testing, but we did have a serum beta hydroxybutyrate, which took a good bit of time to result. And then where I rotated in residency in the pediatric setting, we did have point of care beta hydroxybutyrate testing. And I guess it was really interesting to watch how the clinical pathway changes when right from the beginning you can get a sugar and do a quick test for ketones. It really can dictate your subsequent management. With that in mind, do you think a normal BHB obviates the need for further testing for DKA? I guess how definitive is that point of care beta hydroxybutyrate in guiding your care, if that makes sense?
That's an excellent question. No, that's a perfectly great question. And a beta hydroxybutyrate level, I think, is probably the most specific test for the diagnosis of DKA. If that patient's beta hydroxybutyrate level is normal, the likelihood of them being a DKA is essentially zero. It is not exactly zero. It might be 0.5, but it is so low that you can essentially rule it out in your head. A normal beta hydroxybutyrate level essentially rules out DKA.
All right, George, we've talked about beta hydroxybutyrate. We've talked about acetoacetate. Let's put a pin in diagnostics and move on from the nuances of deciding if these patients have DKA or HHS and move on to treatment. This is what people have probably been waiting for with bated breath as they've listened to us nerds drone on and on in part 1 and then in this first part of part 2. So let's dive into it. First with DKA. What do we need to know about DKA management in 2025?
So this is actually probably the most groundbreaking information that is in this new consensus guideline, because there are a lot of significant changes in terms of the algorithm for DKA management in 2025 compared to 2009 when the last set of guidelines are. So I'm going to break this up a little bit. We're going to start with fluids. So as I have been preaching for a number of years, there's nothing normal about normal saline, especially in DKA. So I predominantly stick to my balanced solutions being lactated ringers or Plasma-Lyte. In the 2009 guidelines, they specifically said your initial fluid of choice is normal saline, 0.9%, and they have not wavered from that despite the mountain of literature that has shown that balanced solutions are better for DKA. So this new set of guidelines has finally addressed the elephant in the room, in that they say that balanced solutions, now they don't say that they're better, they don't say that they're superior, they say they are at least as good as isotonic 0.9% normal saline. So they do say you can either use isotonic saline or balanced solutions as your initial fluid of choice, which I think is monumental. The SQUID trial, which there's now a SQUID 2 trial that's just recently come out, has kind of really revolutionized how a lot of us think about the mild to moderate patients with DKA. So remember that the severity of DKA is completely dependent on the patient's acid-base status. So it has nothing to do with the glucose. It is predominantly all about what is their acid-base status. Are these patients severely acidotic? Is their pH 7.1 or less? That's a patient in severe DKA versus 7.2, 7.3. Obviously, those are going to be more of your mild to moderate DKA. When the SQUID trial came out, they treated successfully patients who were in mild to moderate DKA with subcutaneous insulin, and using the ultra rapid acting insulin. So this is your insulin aspart and your insulin lispro for the management of these patients. And they were started on either a 0.2 units per kilogram insulin infusion. 0.1 to 0.2 units per kilogram injection of subcutaneous insulin of the aspart or lispro, and then rechecked in 2 hours to see what their acid-base status is doing, and so on and so forth. And this was found to be largely successful, and it obviated the need for an insulin infusion, which obviously obviated the need for these patients to go to an ICU. So this is a great tool to use in your mild to moderate DKA, and it's in the new set of guidelines. This was a paper that wasn't published that long ago. And to find that they actually put this in the guidelines is actually very enlightening to see that they're starting to get out of the stone ages with the old school management of DKA and starting to think of these kind of new and upcoming treatment modalities. So a lot of hospitals now are using the SQUID protocol for the management of these mild to moderate DKA patients. And the literature, when you look at the SQUID trial, found that it was at least as good as the insulin infusion. But again, that decreased need for the ICU, which we all know with our big boarding problem in emergency medicine, that getting these patients to have to go to an ICU is obviously slows down care in the emergency department. So getting these patients to be able to go to the floor on the SQUID protocol obviously helps a lot of patients in the emergency department. So this is actually a very, very significant revolutionary thing in emergency medicine, this new use of SQUID for patients with mild to moderate DKA. And then another thing that they said, and the literature on this one is not as robust, so I'm actually a little surprised to see this in the literature, is starting these patients on a basal insulin while they're getting the insulin infusion or the subcutaneous insulin. And so this is your long-acting insulin, your insulin Lantus or Glargine, or your insulin Detamir. These are these long-acting insulins that don't have a peak. Starting these patients on this while you're doing the insulin infusion or the subcutaneous insulin will oftentimes, again, decrease these patients' insulin needs long term. They tend to need less of an infusion. and subsequently get off of the infusion faster, because you don't have to do that guesswork that happens when these patients start to correct in the emergency department or on the floor. A lot of times when you're transitioning these patients off of the insulin infusion, specifically once their anion gap closes and their bicarb normalizes, you have to give them this basal insulin 2 hours before you turn the insulin drip off. And the reason why is because it takes that 2 hours for that to reach that, we're going to call it a peak, but in reality, it's more of this kind of flatline basal rate of insulin that these long-acting insulins do. And once that 2-hour peak has been reached, then you can turn the insulin drip off, and that basal insulin now functions as your insulin drip. So there's been a lot of apprehension about starting that early because they were afraid that these patients were going to subsequently get too much insulin and go hypoglycemic or hypokalemic. And there's been some literature that shows that it's actually very safe to do in this patient population. So they actually wrote this into the new set of guidelines to say that you can start these patients on that basal insulin while they are getting the subcutaneous and or the insulin infusion while they're being treated.
Okay, George, I want to pin down the nuances of the potassium level and the insulin start. Now, the consensus statement specifically notes in Figure 4 graphic that starting insulin with a potassium level 5.0 or higher. They don't say withhold it, though, for lower potassium levels. And in the text, they say to delay insulin if the potassium is less than 3.5. So simply, I guess, George, what is a safe potassium level to start the insulin infusion? And how are you repleting their total body depletion of potassium?
So when it comes to less than 3.5, the picture algorithm does not specifically say to delay the insulin infusion, but the words do say that. And so that's what we're supposed to do. If the potassium is less than 3.5, we delay the insulin infusion starting or the subcutaneous insulin injections. We supplement their potassium to get them above or at 3.5 before we subsequently give them the insulin. So I use 3.5 as my number, as I always have. In terms of how to supplement, I also look at their pH. I think that's super important because if their level is 3.6, but their pH is 6.8, that's a time where I'm really thinking that person's potassium is really, really low. The only reason why is slightly the acidemia is actually going to cause that potassium level to be pseudo elevated. And so that patient's true body potassium is much lower than that 3.6 level is. So in this scenario, if they're in severe DKA with a low pH and that potassium is right closer to that 3.5 range, I actually will give them oral and IV potassium. And what I'm trying to do again is just to supplement the potassium because I know that their total body potassium is low. Otherwise, if their potassium is, closer to like 4.5, closer to 5, and or they have a low pH and they're closer to that level, or if they have a mild to moderate DKA, in other words, their pH is 7.2, 7.3, and their potassium may be 3.6, 3.7, then I'm just going ahead and just using IV potassium in that scenario. And I don't necessarily give them oral potassium. There's some other literature that I think is starting to come around the corner, which is this pH adjusted potassium. So there's some charts that are out there where you can actually kind of estimate what the patient's likely serum potassium is based off of their pH. So I will use that sometimes to kind of give me a sense of what their true body pH is probably closer to based off of their pH, and use that to kind of guide my therapy in terms of what I'm going to supplement their potassium with as well. But a key thing to remember here that a lot of people harp on is that, yes, I feed my patients. I don't give them just IV stuff. I give them oral stuff as well. And this old thought that these patients have gastrointestinal paralysis as a result of their DKA, I think is really kind of fake news. And so if the patient's able to tolerate PO, I will feed them because I don't care what their sugar is when it is elevated. I really want to make sure that they are just not going hypoglycemic while they're on the insulin infusion or the subcutaneous insulin. So I'll let them eat. Let them eat cake.
Cake might be a stretch there. but I definitely appreciate that nuance, that oral glucose as well as oral potassium might be something to keep in our repertoire here as we navigate the nuances of treatment and think about these values, with the ultimate goal, or at least the traditional goal, of closing the gap and addressing the ketosis. With that in mind, we've talked about potassium and even pH-adjusted potassium. Are we worrying about any other electrolytes here?
So if we're speaking specifically about DKA, other than potassium, we're not really worrying about other things. The literature, and actually this consensus guideline, really hits a really good point here, which is a lot of people used to focus on phosphorus. And so the old guideline said that if their phosphorus was less than 1.0, then we should supplement their phosphorus. But literature really hasn't panned out to show that phosphorus really is a significant thing that we need to be addressing in the emergency department, unless they have symptoms of hypophosphatemia. So hypophosphatemia usually manifests as some type of weakness, and the big weakness that we would worry about in this patient population is diaphragmatic weakness. So these patients will develop respiratory distress, and I know that's kind of hard in a patient who's tachypnic from their respiratory compensation from their DKA. Are they developing distress? So if their phosphorus is less than 1.0, we're treating their DKA and they are still a little tachypnic, despite the fact that their pH is getting better, or they're telling me it's really getting hard for me to breathe. We've all seen patients who've had severe DKA who've been tachypnic and they're just sitting there playing on their phone. And tachypnic is I don't know what, but they usually don't say that they're tired. They usually are doing this rapid breathing where we might actually have a little bit more distress in our brain to think, oh my gosh, this person's going to tire out really, really soon. They typically don't. But if their phosphorus is less than 1.0, they have a high propensity to develop respiratory weakness. And in that scenario, then I will supplement their phosphorus. Otherwise, I just leave it alone. There's no real reason. I'm, in general, just letting patients be. I'm letting them eat. And there's a lot of phosphorus in a lot of food, so I'll let them eat and supplement their own phosphorus that way. But I'm not giving them IV phosphorus unless they are significantly having respiratory distress or weakness. And the literature and now this new set of guidelines corroborates that.
Okay, noted. So phosphorus is really only for really severe hypophosphatemia, less than 1, and respiratory weakness. Great. Moving down the list of adjunctive treatments that we sometimes talk about in the context of DKA, where are we with bicarb in these recommendations? Are we giving it, not giving it? What's the deal?
So again, I love the fact that this new set of guidelines has updated their response to bicarb as well. So they used to say that if the bicarbonate level was less than 7, that we should go ahead and give these patients sodium bicarbonate. So a lot of people would just blanket, regardless of what the patient looked like, regardless of what their potassium levels was, they would give these patients who had a pH of 6.99 a slug of sodium bicarbonate, which was universally potentially harmful because there's a lot of potential side effects that come about with sodium bicarbonate administration, hypokalemia being the big one. And in the pediatric population, an increased correlation with development of cerebral edema. So this is something that's really, really potentially harmful, and we shouldn't just be giving all willy-nilly. So thankfully, in this new set of guidelines, they actually say routine bicarbonate administration is not recommended, which I love. There are some certain circumstances where I do think it's important, and they highlight some of them, not all of them. But if a patient has, the 3 that I use it for are, 1, if the patient has profound hyperkalemia. So we're not talking about, 6.1, we're talking about hyperkalemia where we're seeing prolonged QT, potential sine wave, potassiums of like 8 and 9. You're obviously going to give these patients calcium, but you might consider that their acidemia is the predominant driver of their hyperkalemia. And so in that circumstance, I would think that sodium bicarbonate is probably indicated in addition to going ahead and treating these patients with, insulin and fluids and so on and so forth. The second is cardiac arrest. And again, this isn't all comers. your patient who's in DKA, who is in cardiac arrest, a lot of times you're going to throw the kitchen sink at. And bicarbonate is one of the ones where your ACLS drugs don't necessarily work in a severely acidotic environment. So if you see a patient in cardiac arrest who has a pH of like 6.9, it's not likely to be because their pH is 6.9. But if it's 6.7 and less, none of your medications are really going to work in that severely acidotic state. And so sodium bicarbonate in that circumstance is probably indicated. And then the last one, which they do address, is in certain circumstances, a severe acidosis can actually cause hypotension. And that can be related to vascular effects of the acidosis or decreased inotropy from the acidosis. So you're probably going to start these patients on pressors. But if you're getting ready to start a second pressor, you've got this person on norepi, the norepi is maxed out, and the patient's blood pressure is not really just responding, despite the fact that they've had adequate hydration, may think about giving them a bicarbonate administration in that certain scenario as well. But those are really the only 3 times where I really think about sodium bicarbonate administration is in those 3 scenarios. And in those scenarios, I'm not hitting them. Well, in the cardiac arrest, I'm hitting them with bicarb pushes. In pretty much every other scenario, those patients, I usually start with a sodium bicarbonate infusion. So I'm putting 3 amps of bicarb in a liter of D5 and running it at about 250 milliliters an hour. And that's basically, again, just to, one, it gives us some isotonic sodium bicarbonate. It gives us some fluids that we can give to the patient. It helps with that acidotic state and will subsequently help augment all of the other things that we're doing for the patient.
That's an awesome explanation, George, and it makes a lot of sense for me. And, as we talk about the really sick DKA, I kind of want to switch gears very slightly. We often talk about DKA, HHS in the same breath, but I was surprised to read that the mortality rate for HHS is 10 times higher than that for DKA. I also find that clinically it's a little bit more nebulous of a diagnosis, and that made me pontificate maybe we're under-recognizing it. As an example, we have an older woman, she has rip-roaring urosepsis, underlying type 2 diabetes, blood sugar is 725, and she's altered. Should I be looking at osms in that lady? Are we indeed under-recognizing this HHS state? And then finally, what are the nuances of HHS management?
Okay, so HHS is a little bit scarier than DKA. And a lot of the reasons why is because HHS happens over time. DKA happens relatively quickly, and so it can be corrected quickly. HHS is a much, much, much longer management period. And so when we think about DKA, a lot of times in our heads, we probably think to ourselves, I could probably fix this in the emergency department. We should never try to fix HHS in the emergency department. Again, sodium is the problem. And as we know, when you correct sodium, whether it's too low or too high really fast, it can lead to detrimental outcomes. And so this is a scenario with HHS that you certainly don't want to be overly aggressive. And we have these kind of earmarks that we can use to be like, oh, the patient's glucose is 1500. I'm going to try really hard to get it to normal while they're here in the emergency department. And that, my friends, will be a very, very harmful thing to do. This is not what you want to do in the emergency department. So the recommended guidelines for HHS in this new set of guidelines are that we start these patients on a insulin infusion of 0.05 units per kilogram per hour. Notice that is less, despite the fact that their sugar is higher in most circumstances between HHS and DKA. We want to start them on less of an infusion, half the dose of the infusion that we do for DKA. The main reason why, as we talked about with the sodium, is that if we correct their glucose, in other words, we start them on that 0.1 units. Let's say that this person, again, let's talk about my patient that we had earlier with a glucose of 1500, had a sodium of 129. If I drop his glucose from 1500 to 1000 in that first hour or two, I'm going to watch that sodium go from 129 to more of what it truly is physiologically, which might be 140. And then if I continue to drop it further, it might be 150. And I haven't had adequate enough time to water the patient. The way I like to think about these patients is that they have lost all of this free water. Our job now is to rewater them and get them back to a watered state. These patients are anywhere between 9 and 20 liters of fluid down. So that's not something that we're going to fix in the emergency department. And then you're still going to worry about your potassium. The potassium, I still use their recommended guidelines, 3.5 to 5, or if you want to use the Willis rule, the 3.5 to 5.5, which is also going to be fine. Again, you just want to focus on the fact that these patients are going to need their potassium monitored because they're going to be on this insulin infusion for much longer than your patients in DKA.
Okay, awesome. So we've talked about the treatment of these clinical conditions, but unfortunately with the current state of ED boarding, we may actually be able to fix these patients while they remain in the ED. With that in mind, what are the criteria for DKA and HHS resolution that we should be aware of for these patients who have been hanging out on IV fluids and insulin for multiple hours in our emergency departments?
So let's start off with HHS because this one's easy. This should not be, again, something that we fix in the emergency department. So if they are in the mildest form of HHS, in other words, their sodium level might be 122 and their glucose is 1500, that's still not normal. And their altered mental status is still present, but it's maybe not as bad. That may be a potentially someone that you could fix, again, over hours. So if you started seeing that patient at the beginning of your shift and it's the end of your shift, maybe, but this should not be somebody that you fix in 3 hours and say, oh, I did my job. That's, again, more likely to be harmful than good. So HHS, we should not make it a goal to fix that in the ED ever. DKA, I have fixed a number of patients with DKA, and I have actually sent a number of patients home after successfully treating them for their DKA in the emergency department.
So let's say we get there. We get to this mystical place where we have DKA resolution that happens when you're an astute clinician like yourself or the patient has been there for hours and hours. How are we transitioning them? How are we transitioning them off our insulin IV protocols to subcutaneous maintenance protocols?
So this is it's a little bit nuanced, but I actually think it makes perfect sense. So if we have repaired everything in the ED and their acid-base level is, and their anti-gap is normalized, you then have to think about what's the next step. Is this patient going to be someone who you could potentially discharge home? Or is this someone who you think may need to be admitted to the hospital? And obviously, it's going to depend on what prompted them to go into DKA. If it was simply due to noncompliance and the patient has access to their medications at home, then you could potentially transition them off simply by giving them a little bit of their long-acting insulin or their basal insulin, and then sending them home, because that basal insulin will work for the next 23 hours to basically supply them with a, quote, insulin infusion. I'm putting that in air quotes, an insulin infusion while they're at home. So they'll still give themselves further insulin dosing, I'm sure, once they get home, if they have access to their medications. But if it is due to insulin noncompliance and they don't have access to their insulin, then that may be a circumstance where you may need to admit them to the hospital and have medicine kind of deal with their social issues to get them access to their medications. Or if it's a new diagnosis of diabetes, certainly that's not a patient who you're probably going to send home, because they'll need training and education on how to do finger sticks and how to give themselves insulin and things of that nature. If there is an inciting event, I'd have a very, very, very low threshold to admit those patients to the hospital. If they have a pneumonia or a urinary tract infection and it threw them into DKA, even if it's mild, I would not send that patient home with some oral antibiotics and say, you'll be fine. You went into DKA, but we fixed it. But here's some antibiotics to prevent you from going back into DKA. Just go ahead and admit those people to the hospital and let medicine continue to treat them adequately to prevent them from potentially bouncing back into DKA. But the big key here is if you're going to keep them in the hospital, you definitely want to get them off of the insulin infusion. So in that scenario, you're going to give them, again, that basal insulin, that long-acting insulin subcutaneously. Subsequently, 2 hours after you've given them that medication, you would then turn the insulin drip off and that insulin will take over. If you're up to date with the literature and know that you can give the basal insulin at the beginning of the treatment, and you've already given it at the very beginning when you started the insulin infusion or the subcutaneous insulin, then you don't have to wait the 2 hours. Once their acid-base status is fixed and their anion gap is closed, you can just turn the insulin drip off. And that basal insulin will have already kicked in by that point in time. And so those patients don't need any further insulin infusions. And again, if you've done that in your patient who you are potentially going to send home, the main thing you want to make sure is that they have their insulin that they can use. The second main thing you want to make sure that they have is a way to check their sugar. Make sure that they have a glucometer, so that, because those patients can still go hypoglycemic. So make sure that they're able to tolerate PO, that they're able to take their insulin at home, and that they're able to check their insulin just in case they go hypoglycemic, which they shouldn't, as long as they have a normal mental status.
All right, George, let's talk briefly about the gap. In the past, we used to use the insulin to quote-unquote close the gap. And when it was closed on 2 BMPs, we said we fixed the DKA. Now, the gap is not part of this consensus statement, and they note specifically not to use the anion gap in either the diagnosis or treatment assessment of DKA. Why does the gap get no love anymore?
So the gap gets love. I think that the focus here is to remember that the gap can be falsely closed in the setting, especially of a patient getting normal saline. So remember that normal saline causes a non-anion gap hyperchloremic metabolic acidosis. So you may look at their initial gap and it might be 30, and then you give them 3 hours of normal saline and their anion gap goes to 15, and you think to yourself, oh, well, their gap is significantly improved. You check their gap again after another liter of normal saline and it's down to 12. And you think to yourself, oh my gosh, this patient's anion gap is normal. Therefore, I am really close to fixing their DKA, and you're completely ignoring their pH or their bicarb level because you're focused so much on the anion gap. So I think the anion gap is still pertinent and certainly helpful when you're not giving normal saline. But I think the key thing that they're trying to focus people on is that your anion gap, if it was elevated and suddenly becomes not elevated, especially in the setting of normal saline, don't be falsely reassured. I think that's their main focus on why the anion gap does not get as much love as it does. I still use the anion gap in terms of management because I predominantly use balanced solutions. And so the anion gap doesn't significantly get affected until their acid-base status starts to improve.
So with well-designed order sets and nursing-driven protocols, we can fall into the trap of set it and forget it when it comes to DKA and HHS. We have touched a bit on a couple of these things as we've made our way through our discussion today, but any pearls for specific complications that we should be on the lookout for while they're receiving care in the emergency department?
So the big, huge complication that we really need to be aware of is hypoglycemia. And there's these protocols that have come out which are using titrated dose insulin, which I absolutely abhor. And what that is that these patients will, based off of how much their glucose drops, that they will titrate the insulin drip down away from the 0.1 units per kilogram per hour to something less, like 0.07 or 0.05, just based off of the fact that their glucose dropped, despite the fact that their pH is 6.8. So hypoglycemia is real. And this is one of the reasons why I want to know what their glucoses are very frequently. So what I'm typically monitoring when I'm have these patients on an insulin infusion is I will get finger sticks every hour, and I will get BMPs every 2 hours. And the main reason why is I want to see what their potassium is doing, and I want to see what their glucose is doing, and then I also want to see what their anion gap and their acid-base status is doing. In your HHS patients, I'm just checking BMPs, primarily looking at their sodium and their glucose level. And then when their glucose starts to get into the like 500 to 600 range, then I'm essentially titrating my finger sticks to every 1 hour to make sure that they don't go hypoglycemic. So the big complication that you want to look out for is hypoglycemia. The second one that you want to be aware of is hypokalemia, remembering that insulin will push potassium into the cell and can lower they're already total body serum potassium down. So I will monitor their potassium to make sure that it is not dropping too fast, and I will supplement their potassium in that scenario. Again, in both of these, one thing that corrects glucose and potassium really well is food. So if they're tolerating PO, you don't have to worry about their potassium supplementation if you just let them eat. Turkey sandwiches have potassium in them. They have glucose in them. So just let them eat some turkey sandwiches. Let them eat some chips with salt on it. But give them something to allow them to prevent them from going hypoglycemic and hypokalemic.
What a strong endorsement for turkey sandwiches there.
The other big thing you want to watch out for, especially in the pediatric population, is for the development of cerebral edema. We still don't 100% know what causes cerebral edema or what are the inciting events. We have some suspicions, but those suspicions have kind of not panned out to be true. But we just want to make sure the big thing that helps with prevention and treatment of cerebral edema is the early recognition of it. So you want to be aware of it, make sure that you're monitoring these patients' mental status, checking for symptoms such they can be as mild as a headache or can progress to vomiting. And so you had a patient who was vomiting before, now they've stopped vomiting, and then they start vomiting again. You might want to stop the treatment at that scenario, get the patient over for a quick head CT, and treat the patients appropriately with mannitol or hypertonic saline. But just be aware and recognizing that cerebral edema is a real thing and has a very high mortality if it's not recognized very quickly.
Okay. Hypoglycemia, hypokalemia, cerebral edema. Can't set it and forget it. As we wrap up our discussion here, we've talked a whole bunch about treatment, but some of the best treatment is prevention, as they say. So as we're packaging them up for the floor, discharging the now resolved DKA or HHS from the ED, or we are set to discharge home someone who came in just for run-of-the-mill hyperglycemia, how can we as emergency medicine physicians help prevent these presentations in the first place?
The primary prevention, as we all know, is appropriate treatment on an outpatient basis. And so follow up with primary care, making sure that these patients have adequate access to healthcare is going to be paramount in this scenario. And a lot of times in the emergency department, a lot of times we overlook that aspect. You know, we tell a patient as we're walking out the door, make sure you follow up with your primary care physician. And the patient may not have a primary care physician, or they may, because they don't have insurance, may not have the means to pay the co-pays that are associated with primary care physicians, or they may have a primary care physician who is relatively busy and it may be several months before they can get an appointment with a primary care physician. So this is where I think social work in the emergency department is massively helpful. And getting patients in with, there are a lot of clinics that these patients can go to. There's actually even I've sent patients to urgent cares if they didn't have access to the ability to get a primary care physician. You can send them to urgent cares, or just to bring them back to the emergency department. And I've had a number of times where I've had patients who they said, you know what, I can't get in with a primary care physician probably for the next 3 months. And so I will write them for refills of their insulin, or I will tell them, if you run out of your insulin, come back to the emergency department. This is not the most ideal place to get your medications refilled, but if you don't have any other way to get your medication, come back to the ED, go to an urgent care. But social work can help with those as well, because what social workers can do is they can help with lowering their cost of medication. Sometimes they work with drug companies where sometimes they give them coupons, or they know reduced cost medications that they can use, that they can have access to. And so social work has a lot more resources than I certainly have in my armamentarium. I don't know of any of these resources off the top of my head, but social work has access to a lot of those. And so having social work help in this scenario, I think, is going to be key with your patients who don't have access to healthcare or have the ability to follow up with primary care. The next thing to do is to talk to your patients about any potential stressors that may be at home, maybe even potentially dealing with the mental health, as we talked about and alluded to before. Some patients, again, become depressed and they may not have access to mental health resources. And so providing mental health resources, I think, is certainly going to be something that's going to be helpful as well. The key and the goal here is preventing these patients from coming back to the emergency department in DKA, certainly, or HHS again. And I think primary prevention is going to be the key to helping prevent these recurrences in the emergency department.
Awesome stuff, George. So after our really long 2-part discussion, we've covered a host of topics, and we really went from top to bottom through this ADA consensus statement. So I guess, George, what should our audience take away at the end of the day? What do they need for the next shift?
So I'm going to start with DKA. Primary, first and foremost, the diagnostic criteria have changed. Use your beta hydroxybutyrate level, which a lot of people should have access to now. And then glucose level. If the glucose is 200 or higher, DKA certainly should be on your differential. And if they have a history of diabetes, it doesn't matter what their glucose level is. Consider in a patient who comes in looking like DKA, don't rule it out just based off of the sugar if they have a history of diabetes. Remember, euglycemic DKA is a thing. In terms of the management of these patients, balanced solutions now are in the guidelines. So you can use balanced solutions. You don't have to use normal saline. Obviously, shortages may change what you have access to. Hopefully that will be relieved very soon. Insulin, you don't have to put these patients on an insulin drip. Consider using subcutaneous insulin. Consider using the SQUID protocol for the mild to moderate DKA patients. Not your severe DKA, but definitely your mild to moderate DKA patients. Your potassium guidelines essentially stayed the same. If you stick with the Willis 3.5 to 5.5 rule, hey. But they use the 3.5 to 5.0 rule, which is perfectly fine. And then remember to monitor for your hypokalemia and hypoglycemia, and think about pediatric, think about cerebral edema. For your HHS, sodium is not your friend. So regardless of what the sugar level is, consider calculating what the true sodium is so you can see that what their sodium level truly is. But a hint that this patient may be in HHS is if they're altered with a really high blood sugar and their sodium is normal. It is HHS until proven otherwise. And the key here for the management of these patients is focus on not fixing them in the ED. Insulin, 0.05 units per kilogram per hour. Allow them to get watered with your isotonic fluids, and this should be a process that fixes over days, not over a period of a couple of hours. Get these patients upstairs. These patients universally will need to go to the ICU. These patients should not go to the floor because they need their mental status watched and they need their sodium levels watched. So this is a slow process to happen, and it should be a slow process to be treated. And those are my key points. Oh, big one. Don't forget to look for an inciting trigger. Don't just assume it is insulin noncompliance. Think about the 5 I's: infection, ischemia or infarction, infant or pregnancy, insulin noncompliance, and then remember those inhibitors, SGLT2 inhibitors and checkpoint inhibitors. And that's all I got.
Well, Dylan and George, this has been a whirlwind tour of DKA, HHS, and these new consensus statement and guidelines. For our viewers, it's a lot to digest. What I would recommend is take part 1, look at our show notes. We have robust show notes, and we put the key points right at the top of the page. Review part 1, get familiar with the takeaway points from part 1, and dive into this, part 2, with our key takeaway points right at the top of the show notes. So much knowledge, so much learned. George, thank you for your expertise, and everybody, until next time.